Managing a pulmonary embolism does not rely on gut instinct or isolated clinical judgment. It demands strict adherence to a rigid sequential algorithm. Every decision point in the sequence is gated by validated scoring systems. These tools dictate exactly when to test, when to image, and when to medicate. A patient entering this pathway must pass through 4 mandatory phases: diagnostic confirmation, acute triage, therapeutic intervention, and finally, the etiological workup. Following this exact framework is the only evidence-based method to safely navigate the margins between 2 massive threats: the acute risk of a fatal thrombosis and the iatrogenic risk of a severe treatment-induced hemorrhage. The first quantitative gate in this diagnostic pathway is the 2-level Wells score. This tool calculates the pre-test clinical probability that a blood clot is actually present in the lungs. This flowchart illustrates the diagnostic bifurcation. A 4-point threshold forces 2 distinct tracks. Scoring 4 or fewer makes PE unlikely, requiring a D-dimer test where a negative result excludes TE. Scoring greater than 4 makes PE likely. Bypassing the D-dimer, protocol dictates proceeding directly to an urgent CTPA. This imaging step comes with a strict logistical constraint. If that CT scan cannot be performed within 4 hours, clinicians must immediately initiate interim therapeutic anticoagulation while the patient waits for the scan. This rigid bifurcation serves a highly specific purpose. It minimizes unnecessary radiation exposure for low-risk patients while preventing lethal diagnostic delays in highly probable cases. Once a PE is confirmed, the focus shifts entirely to triage. Clinicians determine the patient's 30-day mortality risk using the Simplified Pulmonary Embolism Severity Index, or SPESI. The required setting of care relies on this exact number. A SPESI score of 0 permits outpatient management and early discharge. A score of 1 or higher mandates inpatient hospital admission for 3 to 7 days of acute stabilization and monitoring. During this acute phase, modern pharmacological guidelines recommend starting stable patients directly on a direct oral anticoagulant, or DOAC, from day 1, skipping the traditional use of injectable bridging agents. This table outlines acute DOAC parameters. Apixaban requires a heavy 10 mg loading dose twice daily for 7 days, stepping down to a 5 mg maintenance dose. Contrastly, rivaroxaban needs a longer 21-day loading phase of 15 mg twice daily, transitioning to a once-daily 20 mg dose. If oral agents are unsuitable and parenteral low molecular weight heparin is required, the standard weight-based subcutaneous dose for enoxaparin is 1.5 mg per kilogram, administered every 24 hours. However, enoxaparin carries strict absolute contraindications. The first is severe renal impairment. It must not be prescribed if the patient's creatinine clearance is below 15 milliliters per minute due to the high risk of drug accumulation and bleeding. The second contraindication is a documented history of immune-mediated heparin-induced thrombocytopenia, or HIT, within the past 100 days, or the presence of circulating HIT antibodies. The third is acute bacterial endocarditis, a cardiac infection where enoxaparin introduces an extreme, unacceptable risk of intracranial or systemic hemorrhage. By coupling quantitative triage scores with these rigid pharmacological parameters, the algorithm ensures the intensity of the chemical intervention perfectly matches the patient's acute physiological vulnerability. Once the patient survives the acute crisis, long-term management pivots entirely on defining the exact etiology of the clot. A provoked PE occurs when a patient has a clear, temporary major risk factor, such as major surgery or significant trauma, within the previous 6 weeks. Once treated, this carries a lower baseline risk of recurrence. This timeline illustrates the divergence. The provoked pathway terminates shortly after standard treatment. But an unprovoked PE carries high recurrence risk, acting as a red flag for systemic disease. Unprovoked PE in patients over 40 triggers mandatory occult malignancy screening, specifically a comprehensive abdominopelvic CT and a mammogram for women. This workup extends into specific biochemical testing beyond basic bloods. Urinalysis is mandated to screen for occult urological or renal tract malignancies that might be silently presenting with microscopic hematuria. Serum calcium is also explicitly requested in the baseline blood panel to screen for the hypercalcemia of malignancy, which is frequently associated with underlying squamous cell, breast, or renal carcinomas. In the absence of a transient trigger, the clot is treated as merely a symptom, demanding a proactive, systemic hunt for hidden carcinomas. The next major decision arrives at the 3 to 6 month mark. This is the standard temporal barrier where acute, full-dose anticoagulant therapy typically ceases. As this scale shows, extending therapy indefinitely requires an active clinical calculus, weighing the risk of thrombotic recurrence against the risk of an iatrogenic bleed. To improve that balance beyond 6 months, DOACs can be dropped to a reduced maintenance dose, mitigating bleeding risk while maintaining protective efficacy. But before ever ceasing anticoagulation in unprovoked cases, clinicians must screen for persistent prothrombotic states, specifically antiphospholipid syndrome, or APS. The timing of this test is crucial. APS screening must be considered while the patient is still actively on anticoagulant therapy. Waiting until they stop treatment exposes the patient to the risk of catastrophic recurrent thrombosis. This concurrent testing is possible due to the specific assay design. Solid-phase ELISA assays used to isolate antiphospholipid antibodies are not confounded by the presence of direct oral anticoagulants, allowing for safe and accurate testing during active therapeutic windows. If undiagnosed APS is identified, the patient's trajectory instantly shifts. The condition mandates lifelong therapeutic anticoagulation. This final etiological test completes the algorithm, transitioning the patient from surviving an acute pulmonary crisis to managing a lifelong evidence-based risk profile.